Hey guys, this is Dr. Hub. In case you haven't subscribed, please do subscribe for updates. Malignant hyperthermia. So we are looking at some very important key features. So first is we look at the pathophysiology. So let's look at PP, that is a pathophysiology. The pathophysiology, there is prolonged opening of the functioning, altered, there is prolonged opening. The prolonged opening of the functionally altered. So it is functionally altered ryanodine receptor. So functionally altered ryanodine receptor. So it leads to uncontrolled release of calcium. So this acting on this receptor, it leads to uncontrolled release. So uncontrolled release of calcium. So it causes uncontrolled release of calcium from the SR, that is the sarcoplasmic reticulum, and resulting in a sustained muscle contraction. So it leads to the muscle contraction. Next we move on to the drugs known to trigger the malignant hyperthermia. So what are the drugs which known to trigger the malignant hyperthermia? So the drugs include the inhaled anesthetics. So there is inhaled anesthetics. So inhaled anesthetics, it includes the halothane. So there is presence of halothane. Then comes isoflurane. So inhaled anesthetics which triggers a malignant hyperthermia includes halothane, isoflurane, then the sevoflurane. So halothane, isoflurane, sevoflurane, and also the desflurane. There is desflurane, ether, as well as a methoxyflurane. Now these were the inhaled anesthetics. So what are the depolarizing muscle relaxants? So depolarizing MR, muscle relaxants, this includes the succinylcholine. So it is a succinylcholine. Next, what are the CS? CS means the clinical signs. So clinical signs, what increases the metabolism? So what is the one which increases the metabolism? It is due to the increased EtCO2. Next comes the decrease in the SpO2. So increase in EtCO2, decrease in the SpO2, as well as the metabolic acidosis. Next is increase in the sympathetic activity. So what is present here? There is tachycardia, hypertension and the arrhythmias. Now it can lead to the clinical signs, muscle damage. So muscle damage, it includes the masseter spasm. So there can be masseter spasm, there can be generalized rigidity. Next is hyperkalemia, as well as the rhabdomyolysis. Then comes the myoglobinuria. So there can be masseter spasm, generalized rigidity, hyperkalemia, rhabdomyolysis, and the myoglobinuria. Now there can also be hyperthermia. Hyperthermia is the fever and there is also the sweating. Now let's look at the treatment aspect. So under the treatment, it is the discontinuation of all anesthetic agents. So you discontinue all anesthetic agents. That is the first step. Next is there is hyperventilation with 100%. So there is hyperventilation. So hyperventilation with 100% O2. So there is 100% O2. Then comes the presence of dantrolene. So then you do dantrolene. So dantrolene you give about 2.5 mg per kg and it is given IV. So it is given IV every 5 minutes. Until the episode is terminated. So here the dantrolene upper limit should be UL is the upper limit, it should be 10 mg per the kg. Next is the correction of the acid base. So you correct the acid base. So you correct the acid base as well as the electrolyte abnormality. Then what you do is you cool the patient. Then is a cooling the patient. To learn and grow daily like this, please do subscribe.